Hello, and thank you for taking the time to learn about effective management of asthma in the classroom by viewing and listening to Asthma 101. It is important for all school staff to be aware of the signs, triggers, and treatment of asthma. This presentation is adapted from Asthma Management in the Classroom, developed by the Pediatric Adult Asthma Coalition of New Jersey, sponsored by the American Lung Association in New Jersey. In this presentation, we will cover statistics in Pennsylvania, laws and regulations, the definition of asthma, triggers, action plans, and administration of medication. Asthma is the most common chronic disease in childhood. Chronic means that asthma is a lifelong condition. Asthma is the #1 reason for school absences, which also means many missed work days for parents. Missed school places an academic and economic burden on families. On average, a child will miss a full week of school due to asthma. You, as teachers, coaches, and staff, can make a difference in detecting uncontrolled asthma and help to avoid potential asthma emergencies. Let's talk about asthma in Pennsylvania. From 2003 to 2010, the inpatient hospitalization rate for asthma as the primary discharge diagnosis was 24 per 10,000 children in Pennsylvania. The 3 highest counties on inpatient hospitalizations for asthma were Philadelphia County at 92.5 per 10,000. Delaware County had the second highest rate at 29.2, and Susquehanna County was very close to Delaware County at 22.8%. Clearly, there is a huge geographical disparity in asthma rates between Philadelphia County and the rest of the state. The state is divided up into 6 health districts. As you can see from the map, which outlines the lifetime asthma prevalence among school students by health district, the southeastern part of Pennsylvania, which includes Philadelphia, has the highest asthma rate, while the northwest part of the state has the lowest. As you can see from this chart, the prevalence of asthma among students in Pennsylvania doubled from 1997 to 2009. Unfortunately, this prevalence has continued to increase. Significant differences in current asthma prevalence exist between many population subgroups. The burden of asthma falls heavily on African American and Hispanic children. 16% of African American children have asthma. Between 2001 and 2008, the greatest rise in asthma rates was among African American children at a staggering 50% increase. 8% of Hispanic children have asthma, with Puerto Ricans having a rate of 20% compared to Mexican Americans at 7%. African Americans are twice as likely as Caucasians to die from asthma. African Americans and Hispanics are in the emergency room and hospital more frequently for asthma-related illnesses. Act 187, which was passed in 2004, requires schools to develop a written policy that allows school-aged children to carry and use their asthma medication and inhalers. The policy requires that the child demonstrate the ability to use the inhaler and behave responsibly when using the inhaler. The school nurse or designated staff must be notified immediately following each use of the inhaler. The school's policy will likely require a written statement signed by the healthcare provider informing diagnosis, dose, and frequency of the medication, possible adverse reaction and emergency response, and whether or not the child is capable of self-administering their medication. The nurse practice law does require written notice from a prescriber before medication can be given. For students who cannot self-administer or whose privileges to carry have been revoked, the school must ensure that the prescribed medication is appropriately stored in a location close to the student and inform the student's teachers and coaches where the medication is located. Know your school's specific policy for asthma management. At the start of each school year, find out where your student's medication is stored and who is responsible for administering the medication. Seconds count in an emergency. The Individual with Disabilities Act, IDEA, and Section 504 require arrangements to be made to include all students, even those with disabilities like asthma, to participate in all the educational experiences. This may include field trips, outdoor experiences, using chemicals or substances with strong odors such as art supplies. We will talk about why these activities are important to a child with asthma. Exclusion is not tolerated. Excluding a child from an educational experience based on a health condition or disability is not acceptable. It is mandatory that teachers or other school staff make arrangements with the school health department so that all children have equal access to all class activities. So exactly what is asthma? Asthma is a chronic inflammatory disorder of the airways. Chronic means that it never goes away. When a child has an asthma episode, very little air can pass through the airways. Imagine breathing in and out through a tiny straw. It's very scary. Asthma cannot be cured, but can be controlled with few and infrequent symptoms. This is the goal. Uncontrolled asthma can be life-threatening. What happens during an asthma episode or attack? 3 changes occur that cause the airways to narrow. The muscles around the airways are called bronchioles. During an asthma attack, the muscle around the bronchioles tighten. The inner lining of the bronchiole becomes inflamed. Excess mucus is produced. Notice the difference between a normal bronchiole and that of a person with asthma who is having an asthma episode. How do you control asthma? Remove or reduce exposure to asthma triggers. We will touch on triggers more thoroughly in subsequent slides. Follow the child's asthma action plan. This always includes taking a rescue medication as needed, and if your student is on a daily controller medication, that is included in the written asthma action plan too. Generally, daily controller medications are given at home in the morning and evening. If you have a student in your class who is not taking their controller medication, you may notice an increase in their asthma symptoms. Any change or increase in asthma symptoms should be reported to the nurse, who can follow up with the family and healthcare provider. What causes or triggers an asthma episode? Triggers are irritants and allergens, both indoors and outdoors, that make asthma worse. Triggers are different from person to person, but there are many common triggers, and removing them is important to controlling a student's asthma. Common triggers at school are allergens such as cockroaches, rodents, mold, class pets, dust and dust mites, pollen, and outdoor allergens. Idling vehicles. Some schools have a no idling policy. Find out if your school does, and if not, recommend it. Additionally, humidity, strong odors, pollution, and even perfume can trigger an asthma attack. Tobacco smoke exposure is a universal asthma trigger, meaning anyone who has asthma is vulnerable to increased asthma symptoms in presence of second or third-hand smoke. Almost all schools have no smoking policies. These policies should be strictly enforced among staff and students. Other triggers are illnesses, such as the flu. Children with asthma are encouraged to get flu shots. Strong emotions, such as laughing or crying, can bring on an asthma episode. Some children have exercise-induced asthma. These students should participate in sports, but need to have an extensive warm-up period and have their inhalers nearby. Many students will take their rescue medications prior to exercise. There are ways to reduce classroom triggers, such as minimizing chalk dust. Children with asthma should sit away from the chalkboard and not handle chalk or erasers. Use only scent-free markers on whiteboards and in other classroom activities. Remove all air fresheners and room sprays. Be aware of other strong-smelling products, such as materials used in art or science class and perfume. Stuffed animals and upholstered furniture collect dust and should not be used in classrooms. Carefully choose when you clean, preferably when there are no children in the classroom. Use cleaners that emit minimal odor or that are green-friendly. Your district may have a policy on cleaning products in the classroom. Make sure to check with the school administration before bringing cleaners into your classroom. Keep windows closed at times of high pollen, at times of grass cutting, and poor outdoor air quality days. Minimize classroom clutter, as clutter collects dust. Avoid rugs and upholstered furniture. Do not allow furry classroom pets. Immediately alert school staff of mold or insect or rodent problems. Learn the protocol for reporting problems in your building. Limit eating in the classroom. If possible, control the temperature and humidity. Humidity should be under 60%. Exercise is okay and certainly encouraged. The child should slowly warm up before vigorous exercise and have his or her rescue medication available. Make sure to follow the child's asthma action plan and administer rescue medication prior to gym class or recess, if instructed by their healthcare provider. Medication, asthma warning signs, and when to take action. It is imperative that every child with asthma has his or her rescue medication at school. This slide shows an albuterol inhaler on the left and albuterol vials for a nebulizer on the right. Albuterol is the most widely prescribed rescue medication for asthma. Asthma action plans detail what medications the student should take, depending on their symptoms. Some students take asthma medication every day before and after school. Other students only take medication when they have symptoms, which is their rescue medication. Again, each student with asthma needs access to their rescue medication at school. There are many different asthma action plans available. They are also referred to as asthma treatment plans. The form should be filled out by the child's physician and given to the school nurse or designated staff member and be filed in a central location. This will list the child's medication, dosage, and emergency contacts. Some students may have peak flow values on their asthma action plan. A peak flow is a handheld device that measures how much air a person can forcefully exhale. Peak flow readings can help some children identify what asthma zone they are in. Please remember, symptoms always trump peak flow meter readings. There are 3 devices to administer rescue medication: metered dose inhaler with a face mask spacer, metered dose inhaler with a mouthpiece spacer, a nebulizer machine. To use a metered dose inhaler with a spacer and face mask, shake inhaler, remove cap, attach to spacer. Place the face mask tightly around the student's mouth and nose for a complete seal. Dispense 1 pump of medication. Allow the student to take 5 to 6 normal breaths. Wait approximately 1 minute and repeat with second puff. To use a metered dose inhaler with a spacer and mouthpiece, shake the inhaler, remove the cap, and attach to spacer. Have your student exhale all of the air out of their lungs, then have them place their lips around the mouthpiece to create a seal. Dispense 1 pump of medication. The student then will take in a slow, deep breath. Please note, if the spacer whistles, the child is breathing too fast. The student will need to hold their breath for 10 seconds and then exhale. After 1 minute, repeat using a second puff. If you would like to watch a video on using spacers and peak flow meters, please go to www.paasthma.org/how-2-videos. Next, we will talk about using a machine called a nebulizer. Plug in the machine. Add the medication listed on the student's asthma action plan and unscrew the top of the nebulizer, which is the medication cup. Put a dose, which is 1 vial, in the cup, then put the cap back on the nebulizer cup. Then attach the mouthpiece to the nebulizer cup with valve facing down. Younger children will use a face mask. Press the tubing firmly to the bottom of the nebulizer cup and attach the opposite end of the tubing to the machine's outlet port. Turn on the machine, then put the mouthpiece between the teeth and top of the tongue. Remind the child to breathe through his or her mouth. This is a diagram of a typical nebulizer. It is very important to know when to administer medication. The typical signs of an asthma episode are coughing, sneezing, itching watery eyes, and complaints of a sore throat. Less obvious signs are behavior change, headache, dizziness, excessive redness of the eyes or face, and upset stomach. These are considered early warning signs. Early warning signs are the first signs that a student is having asthma symptoms. As soon as you see any of the signs, follow the student's asthma action plan and administer their rescue medication as prescribed. This will most likely be albuterol. Only a teacher or staff member who has been properly trained may administer rescue medication, unless the child has been authorized to self-administer. Continue to monitor the student for improvement or worsening of symptoms. It will take 15 to 20 minutes for the full effect of the medication to kick in. Later warning signs include wheezing, tightness in chest, difficulty breathing, and a lot of coughing. When these symptoms occur, continue to follow the child's asthma action plan and administer the student's rescue medication as prescribed. Do not delay giving the child their medication. Monitor the student very closely for worsening symptoms. The following are emergency warning signs: very fast breathing, accelerated heart rate, pale or blue face, retractions in the ribs or neck, difficulty talking, cannot count to 10 in one breath, difficulty walking. Listen to the student. They often know if it is an emergency. If there is a true emergency, know your school's medical emergency policy ahead of time, before you need it. Procedures will vary from school to school, but in general, you will call 911 before contacting the school nurse or parent. Stay with the student, but send for assistance. Administer rescue medication as prescribed. Keep other students away from the child to reduce anxiety and fear. Stay calm and reassure the child. Once emergency medical services takes over, contact the student's parent or guardian. Document activities by completing an incident report via your school's policy. In summary, there are a number of steps school personnel can take to effectively manage asthma in the classroom. Identify the students in your class with asthma and talk with the nurse or designated staff member about their triggers, warning signs, and asthma action plans. Take time to understand your school's asthma management or emergency health policies. Have a plan of action to respond quickly when you notice early warning signs. Be aware of the common triggers that were discussed earlier and work with the school staff to remove, reduce, or avoid triggers. Your knowledge, awareness, and action can save a student's life. As stated earlier, asthma is a chronic condition which cannot be cured but can be controlled. A child with well-controlled asthma will participate in all activities, is not constantly coughing, has minimal side effects from medication, uses his or her rescue medication no more than 2 times per week, unless before exercise. The student will have had no hospitalizations or emergency room visits due to asthma. We thank the Pediatric Adult Asthma Coalition of New Jersey for allowing us to borrow some of their content for this presentation. Please review the sources used for this presentation. These are great agencies to obtain additional information on asthma. This presentation was developed by members of the Pennsylvania Asthma Partnership. Thank you for viewing and listening to Asthma 101.